Hi everyone, I just wanted to talk about ulnar wrist pain today for a lot of patients who have ulnar wrist pain after distal radius fractures, from chronic injuries, just ulnar wrist pain. I'm a certified hand therapist and occupational therapist at Soma Hand Therapy in Nashville, Tennessee, and I've been practicing for 7 years. So one of the big things that I do when I treat ulnar wrist pain is I always observe, right? So one thing I check out is the ulnar styloid. That is the thing that pops out at the pinky side of your wrist. It's called the ulnar styloid, and what we're looking for is how much it pushes up or how prominent it is compared to the opposite side, okay? It's a little bit hard to tell with the wrist in neutral, but sometimes you can really tell when they're moving their wrist back, forth, side to side. And so you're observing for any differences in that. You're checking to see, okay, is it really high on one arm, especially if that arm is the one that's hurting? And does it feel better if I do this? So this is the treatment technique that I do. It's relatively simple. So what you're looking for is finding this bone right here. It's a very prominent bone. You can kind of see it right there. You're gonna follow along the wrist crease until you find something that kind of points out. It's not sharp, but it just right there. Sometimes it's tender with certain people, but I do want you to try to get that bone and push into it. And so when you push into it, you may see one of three things. One, the patient winces, ow, that hurts, right? Or nothing, doesn't feel like anything, or a visible relief. So if you find that the patient suddenly breathes out a sigh of relief and they're like, wow, that feels better, then that's a really easy treatment. And that's a really easy thing to do to get that patient feeling better. So why does that work? And what is that doing? So what you're doing is you're locating the pisiform and you're putting it into a more supinated position or pronated position because it's too supinated. And so there's a natural imbalance that happens with the hand. There's a bunch of muscles that get the wrist, right, the carpal bones, as they articulate with the radius and ulna. And there's a bunch of muscles that supinate it, okay? There's really only one major one that pronates it, and that is the ECU. So when you're in a period of doing a lot of exercise and work, and you're doing a lot of work, especially with your wrist extension and your thumb and all of that, your tendency is to strengthen the muscles that get your wrist and supinate the carpus. So when I say supinate the carpus, I'm talking about taking this and turning it towards the pinky, right? So you're supinating the wrist. It's a little bit weird of a concept because you're not doing forearm supination, but if you think about it that way, that's what's happening. So when you take that wrist and you supinate it, it's not just the bones that are not articulating quite right with the distal radius and ulna, but also everything that runs through the wrist. So we're talking the ECU, the FCU, we're talking your EPL, your ECRL, ECRB, everything that goes through carpal tunnel, because your carpal bones make up the floor of your carpal tunnel and your Guyon canal. So you can do this test with literally most hand diagnoses, and every once in a while you'll have a patient that goes, oh, that feels really good. Why? And you tell them it's because the muscles that turn your wrist that certain way that you come in are too strong. And that imbalance is causing it to slightly shift the wrist in a way where everything that runs over it are starting to hit bumps and getting irritated, right? So think of like a train on a track. If the track is just slightly off, what happens? Those wheels are going to get a lot more run down. You're going to get more wear and tear. And over time, you might even get some really bad degeneration, and you may need to replace those wheels. So that tends to happen with people who have really chronic ECU injuries, because all it is this shift is not correctly aligned. So how do you fix this? You take that pisiform and you put that wrist into pronation, okay? And so you can do that with kinesiotape. I highly believe in a lot of Allison Taylor's work. She's an amazing occupational therapist that I think is truly paving the way for a lot of our hand therapy conventional ideas. And one of the big things is using kinesiotape as a way to improve alignment and sensation. So this helps with the proprioception, this helps with alignment, this helps with pain reduction. So you get a small piece of kinesiotape, looks like about a Band-Aid size, and you put it right on that pisiform, no stretch, and then you have them in supination, right? So supination, get that pisiform on there, and then you have them go into pronation, and then you just stretch it pretty intensely, like 75%. And that last third, it needs to be an anchor point. You just rest it right on top, right there. Okay, so you should have like a little piece like this going around like that. And that way you don't have to hold your patient's wrists like this all day long, because that's expensive. You have a high hourly rate. They probably can't afford it. So the other thing that you want to do, because you don't want to rely on kinesiotape forever, right? Because after a while, even though it's a small amount, it does get expensive. You want to strengthen the muscle that stabilizes that carpus in pronation, and that is your ECU muscle. So what you do while the wrist is taped is you have the patient put their pisiform and push it down on a surface, right? So you have them crossed arm like this, push this down on a surface, and you're gonna take your two fingers and you're gonna put it on the metacarpal heads of your ring and your small finger, and you're gonna push up. And so it's an isometric ulnar deviation, wrist extension. At the same time, you're adding a little bit of a boost up with this pisiform on the table. And you have them hold it for 5 seconds. 1, 2, 3, 4, 5. Relax. And you do that 5 times. After 5 times, you're gonna have that patient either go, wow, that feels so much better. Ideally, before you do any of this, you want to find something that the patient is, that's painful for the patient. Let's say the patient has a lot of pain going into wrist extension. Okay, it hurts here in my ulnar wrist when I go into wrist extension. You do the pisiform relocation boost up test. They do it. Oh, it feels better. Tape it. Does that feel better again? Yeah, that feels really good. Why? You tell them why. And then you tell them to strengthen their ECU. Very important on the placement of the fingers. You need to make sure it's on the pinky and the ring knuckles. If you even have it on the middle and the ring, what happens is you end up strengthening the ECRL or ECRB if you put it on the index and long, and that actually does the opposite motion of what you want. So you're not really helping yourself there if you do that. So ECU isometrics, kinesiotaping, and that alone does a whole lot. I've had people who've been to therapy for 10 visits without much improvement. They come to me for 1 and it fixes their symptoms just like that. So if you have ulnar wrist pain, try that out before anything else. And that really helps just kind of solve a lot of problems and give it a try. Again, my name is Juno. I'm from Soma Hand Therapy up in Nashville, Tennessee. If you guys have any questions, just email me. My email is Juno, Juno, @ somahand, SOMAHAND.com. Thank you. Bye.